هاي فتحت الفيديو.
طيب بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. نتشرف اليوم بمحاضرة قيمة جدا بإذن الله من دكتور ياسر أسامة محجوب. ياسر معروف للجميع طبعا، هو يعني صاحب البلاتفورم بتاع زوم المنصة منذ يوليو 2023. هو مشرف على البرنامج التدريبي الافتراضي. Dr. Yassir, he is an associate professor of psychiatry at Penn State College of Medicine in Pennsylvania. He primarily works as staff psychiatrist in an inpatient setting focusing on mature adults and medically complex populations. Additionally, he is a member of the electroconvulsive therapy team, where he treats a diverse range of patients with severe psychiatric disorders that range from severe and treatment-resistant depression, catatonia, severe mood and psychotic disorders, and intellectual disabilities. As an educator, Dr. Yassir Mahgoub is involved in teaching both medical students and psychiatry residents. He has received several awards for his contributions to teaching, clinical services, and research, and has published numerous papers in peer-reviewed journals. His clinical interests include catatonia, mood disorders, and ECT in catatonia, in addition to mood disorders and ECT. Thank you so much, Dr. Yassir, for your efforts, your sharing your science, your knowledge, your experience. The platform is yours. تفضل Dr. Yassir.
Thank you very much. Shukran, Dr. Abdul Ghani, for the kind introduction. The topic today is about ECT, and I named it as Introduction to ECT just to, have some realistic expectation. By the end of this lecture, you cannot be expecting yourself to be an expert in ECT. This is just an introduction, so people can be familiar with what ECT is, how we began with ECT, and to have some idea for the people who wants to practice ECT in the future. This is more of some basic information that is needed for them to know more about ECT. But you cannot be expecting yourself to know a lot about ECT by the end of this lecture. One thing for this lecture, and it's going to be interactive. Interactive does not mean that we're going to open the opportunity for all the questions. All the questions will be passed toward the end. Interactive means that we will be discussing things. I'm going to be asking people for opinion and for their experience and for answers. عشان كده, anybody who wants to contribute, and I will ask them, just basically leave the microphone open, say your name, ما في داعي انك تقول السلام عليكم وازيكم, لا, say your name, your level of training, and just immediately provide the answer, because it's going to be interactive. We're going to leave the questions and answers toward the end because the lecture is heavy. We have a lot of material to discuss, so we'll try to discuss this toward the end if we can. And okay, in any lectures, it's advisable to mention if there is any conflict of interest. If you work with a pharmaceutical company, you have a relation for a pharmaceutical company, or you're making advertisement for any company, because this might affect the level of transparency, or even basically the information provided. You need to disclose this in the beginning. So nothing to disclose. We have some objectives for this lecture, which are: first, we're going to be discussing some historical aspect of development of ECT, discuss evidence supporting the use of ECT for various psychiatric disorders, discuss various potential side effects of ECT, and later on we have a series of videos made by me and my colleague, Dr. Mermando, talking about some practical parameters for treating patients with ECT. First, we'll discuss basically ECT. Anybody knows exactly how did we start? How did anybody think about shocking people as a form of treatment in psychiatry? Where did that come from? Anybody? ايزون عندي
شباب
فكرة.
يا شباب، اي واحد يقول اي حاجه،
صحيح.
whether it is right or not wrong it's no problem. اي زول سمع كيف الاي سي تي بدات، زول ضربوه في راسه مثلا، ولا زول ادوه بقى
patient
هايبوغلايسيميك مثلا، ولا زول حصل له سيزر، ولا عرفوها كيف الاي سي تي.
كويس. patient جات لبنى patient with epilepsy had better mood. Okay. لكن how did we and this is actually one of the starting hypothesis that
by
made people.
accident.
منو بيتكلم؟
فاطمة حسن أرفر.
When you say by accident, what do you mean? What happened?
في قصة بتقول إنه في شيزوفرينيك بيشن يتلقى صرعة كهربائية يعني، وبعدها لاحظوا إنه البيهيفير بتاعته اتحسنت وبقى بيهتم بنفسه وكده.
ما في صعقة كهربائية. By accident فعلا. Everything was by accident. يعني nobody thought exactly, and some people came up with very interesting hypotheses في البداية، لكن nobody thought exactly about shocking people using electricity as a form of treatment. دي فكرة يعني ذاتها بعيدة شوية. طيب أنا أفتكر اللي هي أول حاجة هنتكلم عن سكيزوفرينيا. زي ما أنت قلتي سكيزوفرينيا إحنا بنتكلم عن at some point we're بنتكلم عن 1920 1930. This is the time when people thought about ECT or maybe shock treatment as a form, not shock, convulsive treatment as a form of treatment. كويس. عامر بعدين افتكر بس انا واصل بعده. Schizophrenia at that time 1920 1930 is not schizophrenia nowadays. At that time any patient with catatonia has schizophrenia. Any patient with a psychotic experience, bipolar disorder with psychosis, depression with psychosis, people with autism spectrum disorder, all of these people were categorized under schizophrenia. Schizophrenia at that time, there was no treatment. The first antipsychotic that came to the market, chlorpromazine, I think it came around 1951, 1952 to the market. We did not have treatment. The theories that led to like discussing schizophrenia, it used to be called by Kriplin as dementia precox. It's an early stage of early dementia. People go into a state of mental weakness. There was no treatment. Freud had some ideas and theories exactly about how to manage schizophrenia. And it's more about suppression of emotions, and this is a reaction to suppression of it's defense mechanism to suppress emotions. So we did not have any treatment. So this is exactly, we talk about the background of schizophrenia to begin with in 1920, 1930. Somebody came up with the hypothesis, at that time, and this is like I think it was a Hungarian psychiatrist came up with the hypothesis at that time, which is based on observation, as you guys shared, like Zay Malubna shared, that the hypothesis was people with epilepsy are less likely to have schizophrenia. A question to people again, is that true? هل الليلة people with epilepsy, do they have psychosis ولا لا؟ وأن الكحة ولا صمت الخشم.
والله العظيم مش كحة، عايزين ووبن كف عديل، ووبن كف.
شايف الناس بتكتب في الشات. خلاص
لا خلينا نتكلموا، يا قال لهم
افتحوا الميكروفون وجاوبوا يا جماعة.
تكلموا، there is no problem الزول يتكلم، بس يقول اسمه ارقام وخلاص بس.
أنا مارق الحسن R4. I finished the training. People with epilepsy they do sometimes suffer from psychosis.
I agree with you. أنا زي حتى الناس في الشات كاتبة. The frequency of psychosis among this population is high, so you can get post-ictal psychosis زي ما قالت أسماء هنا في الشات. شايف في ناس بتتكلم حتى مش الليلة على البوست-ictal، inter-ictal. انت الليلة في ناس الليلة they come with disorganized behavior, aggressive behavior, psychosis. بتمشي تعمل لهم EEG and you find some epileptic changes. صح؟ فبتتكلم عن intra-ictal. Inter-ictal, in between episodes, between epilepsy, between a seizure and a seizure. Sometimes they can present with some disorganized, some aggressive behavior, some psychotic behavior. So this hypothesis was not right. Yet basically this was the initial hypothesis. أسهل فكرة إنه okay, this is the hypothesis that they came up with. How can you test this hypothesis? And this is the question. Anybody? So عندنا واحد with the name of Madonna. أفتكر he decided to take some postmortem cuts of brain of patient with epilepsy and in patient with schizophrenia. تتوقعوا لقوا حاجة معينة؟ Some histological changes, any histological changes. What do you expect to find in a patient with schizophrenia? Histological changes, which is very non-specific. ده بعيدين system الجينز.
large ventricle.
صوتية. Can you say widening? This is the MRI finding. ما في الآخر بنتكلم عن histological changes. Widening of the ventricles. لكن histological changes احنا بنتكلم عن they found people with schizophrenia had fewer microglial cells. People with epilepsy had more microglial cells. Very non-specific finding. Yet basically this was like a break-in moment for them. Aha, we're up to something here. There's something between these two populations that proves or just goes on with the hypothesis that we made. The next step, إنه هي how do you give somebody in 1920, 1930 كويس احنا this is exactly the time احنا بنتكلم عنه to give somebody seizures. يعني ما في زول يقول لي بالكهرباء. كويس how do you make this انت خد نفسك في مكان put yourself in their position. How can you induce a seizure in 1930? أي زول.
السلام عليكم.
وعليكم السلام. اسمك وطوالي شاركي.
السلام عليكم. مريم غازي. ممكن by inducing hypoglycemia in patients.
اوكي شكله شايف في ناس قالوا عن الموضوع ده induced hypoglycemia. فاطمه وافتكر برضه في سحر واسمع وفي ناس كتبوا chemically. الكتب chemically. Do you know how other than hypoglycemia? chemical induced chemical شنو؟
السلام عليكم.
وعليكم السلام.
دكتور نيورو ترانسميترز كيميكال نيورو ترانسميترز
بالضبط شنو يعني؟ يعني انت بتدي شنو عشان
الدوب.
البوتاسيوم حتكتب الزول يا هبه. اوكي ولا ادرينالين. افتكر somebody mentioned تترا بنزين not تترا بنزين لكن it's a chemical. طيب انا افتكر اوريكم حاجه في at that time في كانت موضه طالعه. اوكي انت you cause an illness to treat an illness. والحاجه دي it came up from the treatment of syphilis. People with neurosyphilis at that time كويس they were treated with something interesting and somebody got a Nobel Prize for this. People were giving malaria كويس for the treatment. This is exactly what happened. Given malaria and the malaria basically will kill, like with the high fever will kill the syphilis. They had access to quinine at that time. The introduction of penicillin did not come until 1928. So before that time, they were giving people malaria, will cause high fever, will give them quinine. Voila, they treated syphilis. With the same idea, people were using, as we mentioned, basically some illness to cause an illness. One of the idea, and it came actually by accidental, which is basically the chemicals. So this is, as we mentioned, basically some of the historical aspects here of how it got introduced. But one person, insulin, I think, introduced into the market in 1922. There was a patient with heroin addiction, okay? And we're talking about addicts first, who basically accidentally overdosed on insulin. She had a high dose of insulin. She developed a tonic-clonic seizures. And when she woke up, she was better. After that, basically, there was a psychiatrist in Germany who started experimenting on people with insulin. اللي هي كانت insulin convulsive treatment. It became very interesting. The focus of those people at that time was people with addiction and people with schizophrenia. And they were giving people insulin. People will go into seizures. They will wake up and they will feel better. And it was accidental in the beginning, but they started experimenting at that time. One of the basically the things that it was shared. Just a second. حاجة صغيرة كده هنا بثواني. أنا ما شايف السلايدز. Okay. So in Vienna, it started initially, and this we're talking about like in 1927, 1928, and basically people were treated with schizophrenia and basically people with addiction. It became more used among patients with schizophrenia around 1933. They found that people with schizophrenia, again, schizophrenia at that time is not schizophrenia nowadays, had significant improvement in comparison basically to the no treatment. And they started using this in a widespread way. And the idea here into you could cause a noxious stimulation to basically and deprive the neurons of cells of basically of important nutrients, which is dextrose, and that will cause basically a shock in the system. And this will cause basically the neurons to improve and to get better. Mainly we're talking about patients with addiction problem, heroin, that got extended mainly to schizophrenia. And until nowadays, and I've seen this about a year ago, we had a patient who had severe depression and has diabetes and was not eating, was not drinking because of the severe depression. And accidentally, he was getting the regular insulin dose. And unfortunately, the patient had a seizure, iatrogenic seizure. After he woke up from the seizure, they did the $1 billion workup to know exactly what is happening. It was just clearly, it was accidental, seizures from hypoglycemia because the patient was not eating yet, getting his insulin. He woke up and he felt great for a couple of days until the depression kicked back again. So it works. Like, and there's a reason why we're not using this nowadays. So insulin shock treatment, this is the picture for how it was used in the past. This is how they put the insulin, and the benefit of this, other than being effective, it's fast. Once basically they give you the insulin, you go into a seizure within a couple of minutes. It does not take that long. Okay. Madonna basically is the Hungarian psychiatrist who had the idea of the hypothesis between epilepsy and schizophrenia. He tried implementing also the seizures at that time. We're talking about before shock by applying this into human. And the first patient that they had, it was a patient actually with schizophrenia, quote unquote, but right now, like they described the patient to have stupor keratonia. The patient was not eating, was not drinking, was not speaking, was not interactive, was not taking care of themselves. And this was lasted for about 4 years. So according to the, Kriplin, this is dementia precox. According to the literature and the past, this is schizophrenia patient. There's no treatment at that time. And at that time, they were using intravenous camphor. Camphor, we use camphor right now in different medicine. It's not part of a specific medicine. We use it in the form of a cough syrup, expectorant, analgesics, and also for abortion. So it had various reasons why they were using it. And when you give it as an IV, it's an irritant to the brain. The problem with it, that it takes a long time to work. So until you give it as an injection, you don't know how long it's going to work. Sometimes it might take minutes, sometimes it can take longer period of time. Very unpredictable with how long is it going to take, but it irritates the brain. After you give it, you cannot control how the seizure would last, which makes it less favorable. Between the time you give it as an injection to the time the patient will have a seizure, there is an experience of frighten and fear, palpitation, and this can also contribute to the negative aspect of the treatment with convulsive treatment. Yeah, it worked. The patient that they had seizures, good seizure. First seizure lasted 60 seconds, and the patient had 7 treatment. Guess what? Patient woke up after 40 years of being catatonic, complete recovery. That was a major breakthrough in the history of medicine at that time. This is only one patient. So what they did after this is just basically they tried to do this on multiple people, and they had almost about 26 patients in the next few years. And out of this, the outcome of these studies, 10 patients had complete recovery out of the 26. 3 had significant improvement. So we're talking about 50% improvement among these patients who were considered treatment resistant. That was a major breakthrough in the history of medicine. And at some point, they were considering giving actually people who invented convulsive treatment, not these people, but Nobel Prize, but it did not happen. Around the same time, this is exactly when they discovered this is camphor is an irritant to the brain. It can take too long to work. It can be problematic. This is exactly, we know this treatment works, but how to make this treatment even better? One of the chemicals which was used at that time, which is the pentyl tetrazole, it was used initially for experimenting for inducing seizures. And basically, they were using it for testing the effect of anti-epileptics. mainly for abstinence seizures and for myoclonic jerks. So they will give the patient the medication, and then they will induce the seizure with this medication. And this is how they test basically whether the medication is working or not. And also it was used at that time instead of camphor as a medication to induce a seizure. The benefit that it works immediately, so you don't have to wait for about an hour or longer, and it's more convenient. Yet basically we're talking about, even some people were talking about the effectiveness of this pentyl tetrazole being more effective. Between 1930 to I think 1935, 1936, this is exactly when they started testing using this on more patients. And more than 110 patients were studied at that time. They divided patients into acute onset and chronic cases. So patients like it belongs to the same conception from Kriplin and from Kalbam, that patients with schizophrenia, some of them are acute, some of them are chronic. The acute might be reversible, the chronic might not. And they found that basically it was effective more among patients with acute onset of schizophrenia, still has some significant effect among patients with chronic cases. And it was effective, like it might efficient. And the difference between effective, like effective means it is going to work. Efficient, we're talking about the total overall experience. As we mentioned, that people were waking up with sympathetic surge, they were frightened. And this was actually, it was leaving people with a very bad taste and experience. Like, we're treating very sick patients. Some of the problems that started coming up with that is a convulsive treatment. So people, when they had convulsions, they would wake, some very rare, it happened that people woke up with fractures, dislocations, muscle spasms, and it was a problem. So now how to make this effective treatment efficient is exactly, this was the process that happened between that time until nowadays. They moved to the United States around the 1936, and this is exactly how they started trying to make this treatment more efficient in terms of adding a muscle relaxant. So in the beginning of the treatment, instead of having the patient to vigorously have contraction here, they gave patients Curare in the beginning. Later on, I think in 1950s, they added basically succinylcholine instead of Curare. But this was the first thing. They added the muscle relaxants. Subsequently, they were giving people scopolamine, and this is a sedative. So they will start, before they intend to give the treatment, they will give scopolamine as an injection, and the patient will be sedated. After about an hour, this is exactly when they give the muscle relaxant. And when they give the muscle relaxant, this is when they induce the seizures by giving the pentyl tetrazole. And around the 1940s, this is exactly when they discovered the whole hypothesis about the relationship between seizures and schizophrenia is not accurate. And this is exactly when they started discovering that this form of treatment is actually more effective for a patient with depression as opposed to a patient with schizophrenia. Shock treatment became the treatment for every patient. This is exactly when you come up with a new invented treatment, you try to try this on everybody. And they try this on patients with peptic ulcer, ما عندهم treatment, psoriasis. But eventually, this is exactly when they fine-tune things to know this is more effective for a patient with depression, more likely than other patients, than other groups. Okay. A second, check it now. Okay. أخفف السرعة ما في مشاكل. Okay. Electricity use. أفتكر في واحد يعني he contributed. أفتكر ده منو كان مجاهد. He said basically Sirletti was the person who was linked to using electricity. Do you know exactly how the whole idea about using electricity in ECT came from? أي واحد يفتح الميكروفون ويشارك. Because we were using chemicals, insulin and chemicals.
عامر عبد الرحمن, السلام عليكم. R4. I think it's come from some experiments on animals. I think I have another idea in my head that maybe it came from the war as a torturing methods that I thought. Thank you, doctor.
Thank you. Some animals, yes, but it's purely accidental. I'm not sure if it's truly accidental, but basically Sirletti, which is, I think he was a psychiatrist in Italy. he went one time in order to buy meat from the butcher, and he did not have the cut that he wanted. So he went back from the butcher in order to ask him to get the cut for himself. And he found that the butcher was using electricity for pigs in order to basically have them to have seizures. They will get sedated, and it becomes easier for him later on to make the cuts. So this is exactly when he realized that the use of electricity was helpful to induce a seizure. They started experimenting in animals, and initially the place of where they put the electrodes, I'm going to show basically the first machine that they used. The place where they put the electrodes, they will put basically the first electrode on the mouth, the second one on the buttocks or anus, and basically this is what we introduce a seizure. So the seizure will go throughout the body, and this will pass by the heart. This resulted in significant, like in a lot of animals dying at that time because of basically, cardiac arrhythmias. And with time, they started kind of changing exactly where they place the electrodes on the brain, mainly on both sides of the brain. This is exactly which was proved to be a better placement of the electrodes. And now, if you use this was actually cheaper in comparison to camphor and to pentyl tetrazole. It was more effective, and it was safe. And this is exactly where they performed the first treatment in 1938. They had 11 treatments, and it was proved to be effective. They used actually a device which is alternating current. ليها نفس الكهرباء الموجودة في الحيطة دي. Okay. And the wave was 0.2 seconds, and patiently it successfully induced a seizure. They studied 20 people, and they had excellent results. And it was very effective, but this is exactly what they found. It was more effective among patients with depressive illness. Some people said basically I'm not sure and how this was used basically by the Nazis, but what I heard also, they were trying to study the effect of inducing seizures with electricity among patients with epilepsy, and they found this is helpful. So they also applied this among patients with schizophrenia or depression at that time. This is the first device by Seletti. Okay. And after that, the use of succinylcholine, initially they used Curare. They started using succinylcholine as a muscle relaxant. And now the whole idea for inducing a seizure, you want a seizure in the brain. Again, it's not about the physical tonic-clonic symptoms that cause the treatment. It's the electrical changes in the brain that happen with the seizure that seems to be helpful. So when the patient is relaxed, this is exactly when you protect the patient against fractures and dislocation. Some people, again, with the other methodology here, we were using electricity all the time, but some gas inhalations actually, which was so interesting. Fluoroethyl inhalation in 1953. This is a fully fluorinated diethyl ether anesthetic. It's an anesthetic, but when you give it at a higher dose, it can result in a seizure. The benefit, it's immediate. It gets in, it gets out, and it's effective. They compared the effect of actually fluoroethyl inhalation with ECT, and they found they had similar effect, almost the same. With more time, they introduced actually intravenous forms, and this was made. And later on, people did stop using it, not because it was not safe. It was safe, it was effective, but basically the production cost for the gas and competing with electricity was not in favor of doing fluoroethyl. And instead, basically, ECT, like electricity, was cheaper. The gas was not in demand. So and it used to leave people with some unpleasant aroma and an experience. So people stopped using it, but it's a very effective form of treatment. And I've read actually a recent article that came in the Journal of ECT suggesting that people should reconsider this again as a safe treatment. Okay. More time in 1950s, this is exactly where the introduction of anesthesia happened. And again, this is to make people more at comfort and for better tolerability. Nowadays, for any procedure, you don't want to be awake for something like this because just basically it might not be convenient. Nowadays, if you want to go to the dentist, sometimes for dental procedures, they might even offer you to do it under general anesthesia, just for convenience. But for ECT, I can understand this. You don't want to be awake when this happens. And between 1960s to 1970s, the electricity current was changed. So in the past, they were using the electricity دي حاجة الحيطة دي حاجة الحكومة دي كويس. Now they changed this into different ones. And I'll show exactly why. So basically, like, I mean, the electricity that we currently use, this is, we're talking about, it has what we call sinusoidal waves, and it can cause more cognitive side effects. It's very effective, but it can cause more problems. And it can result in reduced neuronal refractory state, just in case you need to re-stimulate. This is the difference between exactly the electrical current was used in the past, دي حاجة الحيطة, or the sine wave or sinusoidal wave. You can see basically that the wave itself between one top to the second top is longer, right? And it's one direction, okay? And it was effective, but it used to cause people to have more memory problems. They changed things to use what we call brief pulse. So this is bidirectional. You can see here, a square here, down, up, down. Okay, so it's bidirectional. And it's just basically, it does not go high as the previous ones. This one, which we're currently using right now, is called the brief pulse. This one is called the ultra brief pulse. And the difference between them is just basically the duration of this, basically of the pulse itself. This is 0.5 milliseconds, and this is 0.25 milliseconds. We use both of the brief pulse and the ultra brief pulse nowadays for treatment. This is another comparison between the sine wave, brief pulse, ultra brief pulse. All their devices use this. There is no difference in efficacy here. Efficacy is the same. We're talking about the efficiency and tolerability of these two treatments. It's better to do the brief pulse and ultra brief pulse. Anybody knows this picture, or where did that come from?
Remove it.
ده منو ده طيب؟
Jack Nicholson.
Jack Nicholson. It's a very famous movie.
Americans.
Yeah.
Actor.
Very famous movies from the 70s, I think, or the 80s. It's came from One Flew Over the Cuckoo Nuts. It's a very interesting movie, and it destroyed the reputation of ECT around that time. It was used as a form of torture. It was used for punishment for patients who did not listen, including Jack Nicholson, who was problematic. And until nowadays, people do not like ECT just because of this movie. But this is kind of, like, give you an idea about how it used to look like in the past. Now modern ECT looks like this. So people they found them in the ICT suites. They're more relaxed before they come to treatment. This is exactly where the sensors, monitors are placed, and patients are under anesthesia when it happens. Now we're going to talk about the placement of electrodes for modern ECT, where we place the electrodes and why. So in the past, electrodes, as we go back here, it's on both sides here, both bitemporal, one side, another side. And I think, like, even the device I saw in Sudan, كان في طه باشا, it looked like that one, please. And both sides of the brain. This is what we call bitemporal ECT. Then, like, this is exactly when you put the bilateral or bitemporal, you put them here on the right side and left side too. And then you have the right unilateral. So one basically electrode is or the paddle is here on the right side, and the other one is on the top of the head or the vertex. And we have bifrontal. This is less common. Those two are the more common: bilateral, unilateral. And we're going to talk about exactly why and how to use and why do we use bilateral versus right unilateral for patients. And then we can change the pulse for the right unilateral. Right unilateral, we can do it with ultra brief pulse. And this is, all right, so basically bitemporal is well known. This is the older one. It's classic, it's more effective, it's faster in response, is more likely to cause memory problems and cognitive side effects and confusion, but it is more effective. Right unilateral, on the other hand, it is not as effective as bilateral treatment, but it's less likely to cause memory problems. It's less likely to cause confusion. And the right unilateral ultra brief, as we mentioned, like the pulse width itself is shorter, is the least likely to cause memory problems and confusion, but it's also the least likely to work better. And I want to ask everybody here, who comes to you for treatment? what patient population are we talking about? Very sick, mildly sick, treatment resistant?
Namarik Al-Hassan, I am R4. The most people who come for ECT, they usually resistant cases, refractory patients, severely ill.
All right. So when you apply any treatment, you have to think about two things. First of all, effectiveness of the treatment and tolerability of the treatment. The treatment has to be effective and at the same time tolerable. But which one takes precedence? Which one is more important? Here until you think about the sickest patients here. So you want the treatment to work. People have tried almost everything. Nothing worked for them. They're unable to live their life. They're unable to eat. They're unable to drink. They're very psychotic or they're catatonic. Here, the effectiveness of the treatment takes precedence as an important factor that you pay attention to, rather than basic memory problems. So some places will start with right unilateral ultra brief, and then when they fail, they move to right unilateral brief pulse. And when they fail, this exactly after they try a couple of more treatment, they go with bilateral treatment. By doing this way of what we call gradually going up and up, just to avoid memory problems, you sacrifice a lot of treatment that is effective. Even patients sometimes might withdraw just to say this is not working for them. Other places, they will try with bilateral treatment. And if memory problems, confusion happen, they switch to the other modalities. By so, until you can get the first effect or the benefit of the treatment as soon as possible. If a problem happened, then you can switch. But at the end of the day, you ask the patient. It's the patient's input that is more important. We provide recommendation, but the patient sometimes they have to decide. So indications, who do we treat with ECT? Is it schizophrenia or who are the patient population? Anybody can share. افتح الميكروفونات وشاركوا.
Suicidal patient.
Suicidal. So we're talking about depression or schizophrenia here?
Depression.
So major depressive disorder, لما نتكلم عن severe that they have suicidal tendencies or are very suicidal. This is one. Anybody else? لسه في الدبريشن ما حنمشي حته ثانيه. لسه في الدبريشن. Any other population for depression?
Hello, this is Lubna. So for suicidal patients, we can use it. For severe refractory depression.
Okay.
For patients with severe physical neglect, like people with stupor, depressive stupor, or patients with like, as I mentioned, severe physical neglect. There are so many uses rather than the depression, like the NMS.
لا احنا خلينا في الدبريشن. خلينا في الدبريشن لسه قبل ما نمشي حته ثانيه. طب I want to ask you a question. Why not using antidepressant for these patients?
Most of the patients, the problem would be the compliance with the medication, the time taken by SSRIs to start giving the effect of antidepressant effect, I mean.
So if you have 100 people with taking antidepressant, how many people are going to respond?
It's almost 60%, 50 to 60%.
Good. If they fail the first trial of antidepressant and you try them on a second trial of antidepressant, you wait and it's effective dose, how many of the people who failed the first attempt going to respond to the second attempt?
Actually, I cannot remember the exact percentage, but it's better. Okay. It's kind of 5 to 10%. I'm not pretty sure.
More, slightly more. So we're talking about close to 25 to 30. Once they fail the second attempt, they want to give them the third attempt of different antidepressants. How many of those people who are tried on the third antidepressant going to respond? It's going to be less, صح?
Yeah, of course, indeed.
We're talking about 10 to 15%. So this is exactly where they took this operationally and said basically people who are tried on 2 antidepressants, they're less likely to respond to the third. This is where they draw the line for treatment-resistant cases. What about ECT? What is the response rate to ECT for depression?
70 to 80% or 85%.
85 كويسة وحتى 90%. We're talking about a huge difference between like ECT effectiveness and medications. But what about treatment resistant cases? What is the response to treatment resistant cases? Those people who tried 2 medications and nothing works for them.
It's more than 50%, more than 50%, I believe, or as I recall.
So almost 55 to 60%. And this is exactly when we're talking about, like, this is a very effective form of treatment for depression. Now, as ما قلتي, some predictors tend to help us with knowing exactly the rate of response. Some people respond better than others. انت قلتي stupor, قلتي suicide. Anybody else?
Assalamu alaikum. Wisdan. R4. Also patients who refuse feeding.
Okay.
Severe depression will refuse feeding.
Keratonia,
And,
malnutrition.
Also severe depression with psychotic symptoms.
Excellent. Older patients, younger patients?
Yes.
Mino?
Oh, older patient.
Older patients, okay.
Yeah.
So these are predictors for good response for ECT, and this can help us sometimes to know which group are going to respond or not. طيب, any predictors for negative response, people who are unlikely to respond to ECT? And pregnancy too, Fatma, صح? Unlikely to respond.
Failure to respond before.
Possible. Sometimes, like if it's applied appropriately, and if you try them on right unilateral ulcer brief and they don't respond, well, this doesn't mean that they're not going to respond. They might need to wait a little bit longer. Whether they tried 4 treatment, no response, and you just gave up, that's not a good response. But anybody else?
Maybe some memories changes or
No correlation.
somehow
No
confusions.
No correlation. Memory problems tend to happen independently. Low stimulus, so this is a mechanism related.
If they have, if the patient has مثلا a recent MI, that may be
These are contraindication. احنا بنتكلم عن predictors of poor response.
predictors. Yes, okay.
Of poor response. So people with personality problems. تفضلي.
Epilepsy.
No, epilepsy get treated with ECT still, and not contraindication. So people with personality problems, I'm not saying like you should not treat any patient with a borderline personality problem with ECT. They must still have depression. But if you think you're going to treat their depression that is coming up from the borderline personality disorder or traits alone with ECT, this is not likely to respond as much as you would like. However, people with borderline who develop the severe depression, they might respond well to ECT. كويس؟ you need to know what pathology you're treating. Is it the depression on top of borderline or the borderline itself that is chronic in nature? Okay. Substance use issues. Also, if somebody is not not using drugs all the time and just basically they're coming up, they're miserable, that's not depression. They have to be clean. They're less likely to be responsive to treatment. So I'm not saying like they will never respond, but I'm not going to respond as much as you want. So negative predictors for response. Organic causes, well, sometimes it can also respond to ECT, but as you mentioned, sometimes like you have to treat the underlying cause, hypothyroidism and other stuff. All right. What do you do if somebody's taking an antidepressant and they're getting to ECT? What do you do with the antidepressants? Stop, continue.
Assalamu alaikum. R1. I'll continue with the medication.
Okay. So they found that basically patients, and it's advised to continue. Some people would sometimes be treated with ECT alone. The problem into the course of treatment, we divide the course of treatment for ECT into three different stages. The acute course, when the patient is having acute symptoms, they're severely depressed, they're not doing well, they're not eating, they're not drinking. You give them the treatment, and the treatment happens at the beginning very frequently, back to back. We're talking about between 2 to 3 treatments per week until the symptoms subside. And after this, we start spacing them out. We call this the index or the acute stage of treatment. After this, some people will decide like they tried every single medication, nothing works for them. And sometimes we go like they continue the treatment for 6 months. We call this time between the time of response to 6 months continuation treatment. After that, some people who tried everything and nothing works for them. انتوا بتشوفوا ساعات زمان في الطهبعشة في ناس بيجوا الصباح ياخذوا الاي سي تي بتاعتهم لسنين and they do well and keeps them away from the hospital. These are we call sometimes it's the first one is continuation. We're talking about here ongoing treatment, maintenance treatment. For people, sometimes for the acute treatment, when they get better and you stop the treatment, within 2 years, almost 80% of them are going to have a relapse. If you give an antidepressant, almost 50% of them are going to have a relapse. So it tends to reduce the frequency of occurrence of depression. Okay. Other indications, catatonia. As we mentioned, the first case that was treated with ECT under the name of quote-unquote schizophrenia was just catatonia. And catatonia can occur during the course of several psychiatric disorders. It's not actually more common. It can happen among patients with mood disorders, mainly bipolar disorder, depression. Among that, also patients with medical problems, patients with schizophrenia, occasionally, and patients with intellectual disability. They all can develop catatonia. The effect size of the response to catatonia, this is higher than depression. احنا بنتكلم عن 90-95% of patients with catatonia, especially after they fail, like, lorazepam treatment, they tend to respond well to ECT. So we're talking about like the more likely people to respond to ECT is catatonia here. However, احنا talking about catatonia is usually severe, not all the time, but you always treat it with the most effective form of treatment. If you have somebody who's not eating, not drinking, not talking, not interacting, or becoming aggressive, excited, you don't want to be using the mildest effect of ECT, which is basically the lower effect coming from right unilateral ultra brief or right unilateral treatment. You use bilateral or bitemporal bifrontal treatment because it's more effective. We have a problem. Patients with catatonia are often treated with lorazepam. And sometimes when we're talking about very severe catatonia, very excited catatonia, the dose of lorazepam can go extremely high. What do you do with lorazepam? Or benzodiazepine in general? So
it will affect electrical seizures for ECT.
Okay. هنعمل شنو طيب?
I think we need to increase the dose.
Okay, excellent.
With the benzodiazepine.
شنو?
With the ECT, I need to increase the dose of ECT.
Excellent.
This with the voltage.
You did this. برضه ما نفع. هتعمل شنو؟ Reduce the dose before ECT, lorazepam. You can, and you might end up with a disaster. So discontinuation can be really a bad idea, yeah, Fatma. So discontinuation of lorazepam or benzodiazepine, احنا بنتكلم ساعات we came across some patients, sometimes they came to ECT for treatment for catatonia, excited catatonia on 30 milligrams of lorazepam. Extremely high dose. You try to reduce the dose, they become even more excited, difficult to control. But getting rid of lorazepam is a challenge. It's not always as you wish. So increasing the dose of the electricity is one idea, but sometimes like you might have something as an antidote, and this can be helpful.
I have one idea. I think we can add some drugs which increase the seizure threshold.
We do.
IV, caffeine.
Yeah.
Yeah.
So caffeine sometimes can be used, hyperventilation can be used, increasing electricity can be used, going with right unilateral sometimes is an option, but أيوة ندى شكرا. ندى got flumazenil. So we give flumazenil sometimes before treatment. And this can help you still maintain the patient on lorazepam, and at the same time also give the treatment. Believe it or not, some of these patients with catatonia, they do better when you combine both treatment, ECT and lorazepam. And once ECT effect is kicking in, you can gradually later on, after a couple of treatment, wean them off lorazepam easier. Those patients who were treated with 30 milligrams, we're able to wean them later on with an ECT kicked in all the way to close, I think, to 6 milligrams. Sometimes, like, I mean, it might take a little bit longer. Lakin is effective and it can be helpful. A more frequent session too. All right, let's move on to the next population. Neuroleptic malignant syndrome. Anybody can share with us the criteria for neuroleptic malignant syndrome?
Fever, autonomic instability, fever, autonomic instability, high CK.
Rabdo, altered mental status. Okay.
Yes.
And there might be other features.
Yes.
Among patients with keratonia, sometimes you might come across some people who present with keratonia, and on top of this altered mental status, rhabdomyolysis with increased CK, autonomic instability, and fever. And they get better also with ECT. What does that sound like? These patients are called malignant keratonia, by the way. And it resembles exactly the NMS. And يعني حتى في literature, they're talking about them. They have the same pathology. They have the same response to treatment. And NMS respond really well to lorazepam. In your book exam, sometimes in the book, people will love the option of bromocriptine with dantrolene. Bromocriptine with dantrolene, they don't work well. They don't work well. And sometimes in resistant cases, people use ECT. And we had patients being referred to us from medical floors, coming by the ambulance with nurses. They're covered with mittens, and they get treated with ECT. And sometimes in the ICU, they're really sick. Nothing worked for them for their NMS. And we treat them with ECT, and it can be a life-saving option. So it's not uncommon, but it's usually not a first option treatment. It's usually when you fail the regular options. Okay, and then treatment-resistant conditions, اللي هي الحاجات المعروفة, schizophrenia, we still use it. It's not a first option. People sometimes might combine it with other options like clozapine. And usually they don't respond with 6 to 12 treatment like the depression. Usually sometimes people with schizophrenia might require more. Schizoaffective disorder, sometimes when they present with depressive or mixed presentation, bipolar, manic, or mixed treatment-resistant cases. Patients with intellectual disorders when they present with repetitive behaviors like agitation. And this is exactly when people have been talking about the overlap between autism spectrum disorder as well as basically keratonia. Mechanism of action. Does anybody know exactly how ECT works?
It's make some disturbance in neurotransmitters.
Okay.
Mostly dopamine, serotonin, and so.
Okay. Not wrong. Anybody else?
It's
not clear yet.
منو قال not clear?
فاطمة حسن.
أنا حييكي. Very not clear. So this is exactly when people started trying to understand exactly how does it work. Nobody can know for sure how does it work, but they try to apply their understanding about depression. And basically, we're talking mainly about depression, understanding about the mechanism of depression itself, the mechanism of antidepressants, and if there's any similarities in ECT before and after. So as you mentioned, we had initially for the hypothesis of depression, we had the monoamine hypothesis, where basically there's a disturbance in monoamine, serotonin, norepinephrine, dopamine in depression in some areas of the brain, and basically how antidepressants tend to change this. So before and after. And they found sometimes, like in patients with ECT before treatment, that some serotonin, it's like 5-hydroxytryptamine 1 is basically, and 2 might be different in some areas of the brain before treatment, and how ECT can be making a difference and changes after. But at the other hand here, they found like this is mainly, we're talking about serotonin, but they found also some dopaminergic activities also being affected in ECT. Some areas of the brain. Other theory talking about not just the monoamine hypothesis, and this is based on our understanding or hypothesis of how depression can happen, because now people are thinking beyond the monoamine hypothesis for depression, GABA and glutaminate. And glutamate are basically the primary inhibitor and excitatory neurotransmitters in the brain. They have a role in regulation of seizure threshold, and they also have a role also in nowadays some of the theories and new medication being involved in the treatment of depression also are involved in the GABA receptors, glutaminergic receptors. This is more argued to be mainly in patients with mania, but also some depressive medications have been used actually, like nowadays ketamine and the role with glutaminergic receptors has been argued here. And this is exactly where ECT might have an overlap. NMDA antagonists like ketamine. Okay. Other theories, we talk about inflammation, and now we talk about correlates in patients with depression before and after. So people think right now that patients with depression tend to have more inflammatory markers, and after treatment, these inflammatory markers tend to improve. And this is found with SSRIs tend to have an anti-inflammatory effect before treatment, mainly with interleukin-6 and tumor necrosis factor alpha. And basically after treatment, this tends to improve. They found the same among patients with ECT. Okay, just skip, I have to go on. Other newer theories talking about basically circuits in the brain between patients with, in patients with depression and in patients with no depression, or even before treatment and after treatment. And they study some certain areas of the brain. We're talking about the prefrontal cortex, cingulate gyrus, hippocampus, occipital gyrus, lateral, actually temporal and parietal lobes, right? These, they call it an area of interest. And with basically fMRI, they check the activities of the brain and the metabolism in certain areas. And sometimes when it's active or hypoactive in cases with depression, they tend to compare it after the depression and they see the differences. And this is exactly where the recent interest focused on circuits, the connection between one area to another area in the brain. And they found some areas to have a different effect before and after treatment with the ECT. On top of this also, they focus on the hippocampus size. As you guys can see this in this picture in the MRI. And they found that the hippocampus size might be different among patients with depression before treatment. When you give them antidepressant, it tends to kind of normalize and increase. This effect was also found in ECT. And this led to some idea, actually the hypothesis that some neurons tend to still proliferate. I'm not talking about some of the glial cells tend to increase and the synapses tend to improve and synaptic plasticity tend to improve with the treatment with ECT. All right, we're going to come to the side effects of ECT. And anybody can share with us the side effects of ECT. Juana.
Yes.
Seizures? Yes. Prolonged seizure can be a problem until you're trying to induce a seizure, but the seizure is not too long, not too short. When it's too long, this is a problem. You can terminate this in the treatment. Amnesia, headache, amnesia.
Cognitive problems.
Muscle pain.
الجاي cognitive منه؟
تمارق.
cognitive دي بالضبط شنو طيب؟
I mean memory problems.
Okay.
Memory impairment. Some sort of disorientation in time person. But it's usually temporarily.
Okay. Keep to your answer and I will get to this at some point. شايف الناس بتتكلم عن headache, amnesia, في الناس بتتكلم عن muscular pain, muscle pain, confusion.
Dislocations, I think.
دي ما بتحصل اليومين دي الكثير. Very unlikely. مع المصدر relaxers بتكلم عن modern ECT is not the same. طيب retrograde amnesia خلينا نمشي. طيب this is a study that showed exactly the frequency of side effects to ECT, headache being the most common, and then we're talking about memory problems. We're going to be talking about memory problems being different. Cognitive problems, confusion, muscle aches, nausea, acute confusion, cardiovascular, cerebrovascular, prolonged seizures, manic mood swings. Sometimes this might trigger manic episodes for them. So these are the most common side effects. عشان كده before treatment, before any treatment, هنا ده مثلا in the United States, every patient, before they get the anesthesia, they get Toradol as a pain medication. It's an NSAID. They get Zofran as an anti-emetic, anti-nausea medication because these are easier things to give. وبعدين بنجيب a muscle relaxant, بعدين we give the anesthetic and then a muscle relaxant. And this can tend to help with some of these symptoms. The confusion, memory problems tend to happen independent of the response to treatment. And many ways of how we can handle things here. How we can switch the treatment from bilateral, unilateral, ultra brief, and some of these options. This can help you to have an idea about the cognitive side effects. They're not specific. They can be different. The most common, as we know, can be anterograde amnesia. This is impaired ability to have new memories after ECT. Retrograde is more common. They're not going to forget who they are. They're not going to forget their name, their family. They might forget a password for a website here and there. They might forget what they ate for dinner the night before. So subtle things. The memory problem confusion tend to happen more frequently with bilateral treatment, but bilateral is more effective. It tends to happen more frequently as we give the treatment back to back. So when you do three treatments per week, it's more likely to happen. When you space out the treatment, it tends to improve. Some anesthetics might have more relation with memory problems. Some medications. Nowadays, some people, when they take lithium, which is common among patients with bipolar disorder, mood disorders, literature does not suggest that there is a clear correlation between lithium and cognitive problems. I've seen it happening every single time. So they ask the patient to hold lithium the night before and the day before or the night before ECT. For my end, I just try to avoid them as much as I can, not a must. Subjective memory difficulties and impaired executive functioning. So why do we do the treatment when we call bilateral, right unilateral treatment? Why is it the right side, not the left side? Any idea?
Non-dominant hemisphere.
Okay. So
the patient who use the right hand, his memory on the right side.
Okay.
So when we use unilateral, we can save his cognitive function, like a memory.
The left side is more likely than not to be the dominant hemisphere. هرجع لموضوع الليثيوم. لكن انت when you spare it, you're less likely to affect the autobiographical memories. This is for right-handed people, but what about left-handed people?
They will use in the different side.
Among left-handed people, almost more than 2/3 of them, or 3/4 of them, they also have the left side dominant. So still almost everybody, we do right unilateral treatment on almost everybody. If you want to use right unilateral treatment. بالنسبة للليثيوم, lithium is this is an observation. It has caused significant confusion, memory problems with ECT. The advice, and again, this is not based on studies. Studies did not show this result. Yet I've seen it happen several times. The advice is to hold lithium, not to give lithium on the day or even sometimes the night before ECT. So it's advised to give lithium once a day, by the way, once at night. Some people give it twice a day. If you're giving it twice a day, don't give it in the morning, don't give it the night before. Skip it. If you're giving lithium at night, don't give it the night before ECT because it can result in significant confusion. Okay. طيب.
What about the lamotrigine? Lamotrigine, is it effect with ECT in a patient with a mixed feature of bipolar affective disorder?
So lamotrigine has a role in bipolar depression, not mixed. And it's an anti-epileptic medication. If it's needed for epilepsy, I will keep it. حتى valproic acid, if somebody's taking valproic acid for epilepsy and they come for ECT, we need to control the seizures. So we'll still give valproic acid. I'll try to work around it. But let's say if it's given for bipolar depression and it's not working, and it's interfering with ECT, I'll get rid of it. Like for cognitive problems, as we mentioned, older people are more prone. When we give bilateral treatment is more common. When we give more frequent treatment is more common. Some medication might have a role in causing this. Some anesthetic might have a role in causing this. Modality, okay. And all right. Let me just check one thing here. بتكلم عن الليثيوم and the steady state. You still like the ECT has a role in treatment. So you're giving two treatments here. Both both lithium as well as ECT. So if it affects one, you need the response from the second one too. All right, this is the ECT device that we're using. And I have some videos here talking about practical points about ECT use, especially modern ECT. I did this video with my colleague, Dr. Charles Marmondo, one of the psychiatrists and ECT physicians here in ECT with us. And it talks about several points here, and I'll run the videos for you guys.
Hello, I'm Dr. Charles Marmondo. I'm an associate professor of psychiatry for the Penn State College of Medicine, and I am an ECT psychiatrist.
So welcome, Dr. Marmondo. I'm happy that we're going to have you here today to discuss some practical aspects of ECT. Today, we're going to be discussing some aspects related to ECT consults, procedures for the ECT, what we do for the day before ECT, the day of ECT, pre-rounding for ECT, how do we do the procedure, interpreting the EEG itself for the ECT, and to how to manage some specific kind of matters related to the treatment. So we'll start first with the ECT consults. So to begin with, why do we do ECT consults?
Well, we do ECT consults. This might seem obvious, but we want to know who's going to actually benefit from ECT. And I know Dr. Mahgoub has probably went over this in his lecture, but MDD, major depressive disorder, for example, is a very heterogeneous disorder. And not everybody with an MDD diagnosis will respond to ECT. So there are certain prototypes of depression that we look for that we think will actually respond to electroconvulsive therapy. The second second most important part, of course, will be risk-benefit assessment. ECT does have side effects. Patients need to be able to tolerate general anesthesia, right? So they need a healthy cardiovascular and respiratory system. And you can think of ECT actually almost as a stress test. So patients need to be able to tolerate all of these things. And these are the two main points I would say why we perform ECT consultation.
All right, thank you very much. And I also kind of think about some expectations related to ECT that people might not understand what is ECT, question related to ECT. Do they get the chance to discuss the procedures of an expectation of ECT with you?
Oh, absolutely. You know, and we're totally transparent with our patients. As most people probably know, we don't have many biological markers or lab tests or imaging studies to say, yes, you're going to respond to this. So we'll be transparent with our patients. We'll let them know what we think their chance of responding is, and we'll have this discussion. Like I said, there's an important sort of risk-benefit analysis that always occurs.
Thank you. And with regards to assessing the understanding about capacity assessment, like any other treatment, do we do this during ECT or before ECT?
Oh, absolutely. Absolutely. Because a large population of the patients we treat, well, there's a subgroup of patients that we treat, I should say, that do not have capacity for ECT. And these are mainly going to be our catatonic patients, or perhaps even our psychotic depressed patients. Typically, these patients will assent. So in other words, they'll say, sure, I'll do ECT, but they don't have the capacity to understand why they're being treated, what the potential side effects are, what would happen if they're not treated, all the sort of core aspects of what capacity to make a decision is.
Thank you. And also for informed kind of consent, do you tell them about potential side effects? What kind of side effects do you do you discuss that with them?
Oh, yeah. So everybody has access to the internet nowadays, and probably the biggest side effect that our patients read about are going to be the cognitive side effects of ECT, which of course can be nerve-wracking, right? When people think that they're going to lose their ability to remember certain things like this, can be very bothersome. So we do talk about that. Of course, not all patients experience cognitive side effects, but some patients do, and to varying degrees. So we discuss this.
Thank you. And nowadays we have more modalities for how we perform ECT in terms of kind of applying the electrodes between bilateral, unilateral, right unilateral, ultra brief. Is that something that you guys also discuss in the ECT?
It is something we discuss. Patients who are very concerned about memory side effects, or patients who we think will still benefit from right unilateral ECT, this is something we do, because of course, right unilateral ECT does seem to have a better cognitive side effect profile.
Okay, thank you. And in terms of also support, do you assess that the patient has support to come here for treatment? What do you guys ask for?
Yeah, so for our outpatients at least, inpatient is a different story, but for our outpatients, because they are receiving general anesthesia, they cannot drive once they leave here. So typically these patients need to be able to be driven here 2 to 3 times a week for several weeks. Most of our patients require anywhere from 6 to 12 treatments for the original index series of ECT.
All right, thank you very much.
طيب الموضوع الثاني هنا
الثاني هي بنتكلم عن الاكسبكتيشنز بتاعت الاي سي تي. What to tell patients about ECT.
So now we'll move on to talk about pre-ECT expectations and procedure. What do we tell the patient to do and what to expect before ECT? So can you tell us a little bit about what to tell the patient the day or the night before ECT and before they come here for treatment?
Yeah. So all patients, regardless of medication regimen, are going to be NPO after midnight before the procedure. So nothing by mouth after midnight, the night before the procedure. Now, some patients might have different medicines in the regimen that they take. And because what we do here at ECT is that we're trying to induce a seizure, it just so happens that a lot of psychotropic medications can do one of two things. They can alter the seizure threshold by either increasing it or decreasing it. So depending on these medicines that they're on, so for example, if they're on Depakote, right, which is a mood stabilizer that we often use, but it's very anticonvulsant, we might have them hold that dose the night before and the morning of, for example. That would also be true for things like benzodiazepines, et cetera. The other could also be true. Patients could be on high dose of proconvulsant drugs, perhaps bupropion. We may have them hold that medicine the morning of.
What about medications for blood pressure? What about medications for diabetes?
Yeah, so blood pressure medication we always have the patient take because during the procedure, of course, there's a huge sympathetic discharge. So the patient's blood pressure, their heart rate, this stuff is all going to increase. So it's important that they take their antihypertensive before the treatment. Our diabetic patients is a little bit more complicated, especially at our institution, because we treat in the afternoon. So they're NPO for a long time. So you can imagine insulin and other oral hypoglycemics might be problematic for this patient population. Typically, we hold oral hypoglycemics the morning of treatment, and we usually half the basal insulin dose, and we do blood sugar checks before and after ECT.
Thank you. Why do we need to make the patient NPO? What if they eat or drink? Is that going to be problematic?
Yeah, so there is a risk of aspiration, which would be problematic during general anesthesia, of course.
Got it. Thank you very much. Any concerns about some of the new medications that are being used for weight loss? Nowadays, you hear about the GLP-1, medications like Ozempic and Mounjaro. Do they interfere with ECT?
They interfere with the anesthesia, yeah, because they slow gastric emptying. So this also pretty significantly increases the risk of aspiration. So what we do, if patients are simply on for weight loss, we have them stop that medicine. It's at least a week clearance for most of them. If patients are on it for more like metabolic reasons, like diabetes and things like this, we have them switch to an oral version of the medicine where the half-life is much shorter and they can only hold it for about 24 hours before the procedure.
Thank you. Now, we get sometimes across some patients who are extremely anxious about procedure, about getting to treatment, about being under anesthesia. And they come to the ECT, they're panicking, they're having bad anxiety that can prevent them from coming in the future. Is it really problematic to give them lorazepam before treatment?
No. In fact, it's probably encouraged. We don't want patients suffering here, so a small dose of intravenous benzodiazepine can clinically go a very long way for anxiety and usually not interfere with ECT too much.
What if it interferes with ECT? Is there any way of reversing this?
There is, and this happens a lot. I'll refer back to our catatonic population where they're often on very high dose benzodiazepines, for example. And there is a reversal agent that exists that's available intravenously and works within minutes, and it's called flumazenil. So in patients where they are on very high doses of benzodiazepine, we'll administer intravenous flumazenil about 4 to 5 minutes before induction of seizure.
Thank you.
All right. Next, before ECT, before we treat the patient, we do clinical rounding. And we're going to be talking about the clinical rounding for ECT.
So we're here in the recovery room where pre-ECT rounding happened when the patient arrives here before the treatment and also where the patient recovers after the treatment. Dr. Mormando, can you tell us a little bit about the pre-rounding process? What do we do when we assess patient before ECT?
Sure. Yeah, from the physician standpoint, we're checking in on mainly the interval history of what's happening between treatments. Here in the States, we typically treat our patients during the index series of treatments anywhere between 2 to 3 times a week. So 2 main things. We're checking in, is there any effect of ECT yet? Is the patient starting to feel better? We do this through objective measures. For example, we do the Beck's Depression Index, which is a self-screening tool that we rely on. We do this serially about every 4 treatments. So that's more of our objective measure. But then, of course, we sort of subjectively check in with the patient to see how their signs and symptoms are improving or not improving. Second most important thing would be tolerability and side effects. So we check in on how is their cognition. We do sort of a gross cognitive assessment via the mini mental status examination. It tests various domains of cognition. Again, that's more of our objective score or measure that we use, but then we check in subjectively. I think self-report for cognition is very important. So we ask the patient, are you noticing any cognitive side effects? We ask the family, are you guys noticing any cognitive side effects? And then other side effects that patients might experience are things like muscle aches, prolonged headaches after treatments, things like that. But generally, it's actually quite well tolerated.
Okay. Do you check if there is any health issues that happen in between treatments?
Yes, that's a good point. We always check in to make sure, to see if there are any medical changes to the patient's status.
Do patients require any clearance before they come to ECT?
We do require medical clearance. Yep, and that usually just clearance from the primary doctor is sufficient. However, if it's a more medically complex case, which we do treat here, for example, patients with extensive cardiovascular disease or cerebrovascular disease, we may require extra clearance from, say, a cardiologist, where a stress test prior to treatment might be needed, things like that.
And we're not talking about any contraindication here. I think we're talking about trying to modify some of these risk factors that put people at higher risk and increased risk for developing any problems after ECT. But we're not abandoning them.
No. In fact, there are no absolute contraindications to ECT, only relative contraindications. Nonetheless, it's extremely important.
And what happens here post-ECT for recovery?
So once the patient is rolled out here, that means that their vital signs are stable from the operating room there. They're breathing on their own. That's also very important. So the depolarizing agent is already out of their system. They're breathing on their own. We bring them out here. Nursing takes over and they do, I think it's every 5-minute assessments. The patients are typically getting oxygen. We're doing vital sign assessments, serial cognitive assessments. And I would say usually about 15 to 20 minutes, the patient is already becoming lucid, asking for something to eat and drink. It's a fairly quick process.
How long does it take for recovery usually for a patient?
Patients are in the PACU on average about an hour post-treatment.
All right. Thank you very much.
Right. Last video we have here is in the ECT room itself. For obvious reasons, we cannot have a video of the treatment itself, but what we do during the treatment as well as the EEG changes, I think we're going to be discussing this in this video.
So we come back here to our ECT machine here. And what kind of ECT machine do we use here?
This is a Thymatron System 4 ECT machine. It's a brief pulse device and it is a constant current device. It's 900 milliamps.
Okay. And what do we do? Like, how does it work?
Well, it's quite simple, actually. You'll see that we have our 2 stimulating electrodes. These are applied to the patient's scalp, depending on what electrode placement we're using, which would be either bitemporal, bifrontal, or right unilateral. Those are the 3 main placements that we do here. And then we have here our recording electrodes. It's a simple 2-lead device. We have 2 prefrontal leads. These are the red ones here, our ground and our other leads here. So that's all we use for our electroencephalogram. It's a 2-lead device, 2 prefrontal leads, which go right here on the patient's forehead. And that would read out of the machine here, it comes out on a piece of paper. The machine could also do EKG as well as EMG, but we use our anesthesia monitor for the EKG instead of the Thymatron. But we do use it for EMG. So what we do prior to administering the succinylcholine, which is our neuromuscular blocker, we use a blood pressure cuff as a tourniquet, and we inflate that prior to administration of the succinylcholine, so it doesn't go to the patient's foot. And we have an EMG monitor there, and that allows us to measure the motor aspect of the seizure.
Right. Thank you. And before we start the treatment, do we check basically what are the baseline for electrical activity of the brain? Does that help you to monitor the seizure activity itself?
To an extent it does, but it also tells us that the electrodes are applied correctly. I'll give an example of what a baseline EEG looks like here. So here is the left prefrontal lead, here is the right prefrontal lead. This would be the EMG, And here's EKG, which I told you guys we actually don't use. This is very typical of a baseline EEG, mainly low voltage alpha and beta waves here.
So when we say baseline, like, I mean, you know, we have some activities when the brain's, like when the patient is asked to open their eyes, when some activities when the patient is asked to close their eyes. Is that important?
Yes, I mean, it's not part of the seizure, of course, but the EEG will record eye movement. So you'll see if we ask the patient to move their eyes, you'll see a large sort of polarizing reflection in the EEG.
Why do we need a baseline?
The baseline could assist us in telling us when the seizure is over. And that might be shown best by maybe looking at an EEG.
So let's, you know, can you show me more of an EEG? How do you know that the seizure happened?
Yeah. So we just looked at the baseline here. This is a very typical EEG that Dr. Mahgoub and I collected just the other day. So here's the beginning of our typical seizure pattern here. There's this beginning segment where there's neuronal gathering, where the neurons are starting to seize and get larger. And these are probably what we would call theta waves, okay? And as the seizure progresses, this is normal, by the way, it continues to progress. It goes into, you can see these waves are a little bit taller, but also wider. So what that means is they have higher amplitude, but lower frequency. These are our delta waves, and these are very, very important when we look to quantify the electroencephalogram. The presence of delta waves is actually very important to tell us whether or not it's going to be an effective treatment. Not all EEGs are the same. So you're looking at a nice run of delta waves here. You can also see a spike in wave pattern. You can see the spikes, these sort of high frequency, sharp spikes. That's what we call a spike in, these are epileptic spikes, spike in wave pattern.
How do you know the seizure ended?
Let's take a look. So you can see that we had somewhat abrupt cessation of seizure activity. This is actually a little bit more gradual. Sometimes a seizure will end, if you guys look back here, sometimes it will stop on a dime. And you'll see what we look at here. This is called post-ictal suppression. If you compare it to the baseline, you can see that the EEG post-seizure is actually a little bit quieter than the baseline EEG. That's why that baseline EEG, like Dr. Mahgoub asked before, is so important. It's helpful to look at, and it gives us an index. Well, how suppressed is the post-seizure? We call it the post-suppression index, and we compare it to the baseline EEG. So this is okay, I would say. It might be hard to see from here, but there are QRS complexes.
Oh, you mean like the brain becomes silent and it picks the next activity, which is coming from the heart?
Exactly right. So the brain is so quiet, and also the EEG is such a sensitive voltmeter that it will actually pick up electrical conduction from the heart. So it's pretty neat. So this is decent suppression.
So how do you know, like, if you had a good seizure that, you know, tend to, you know, provide a good treatment? What is a good seizure?
So again, not all EEGs are equal. And we figured this out over the years. So what makes a seizure good, an EEG good? I would say probably the most important aspect would be the post-ictal suppression. That's extremely important. There are theoretical reasons why that might be important. I think that's outside of the scope of what we're talking about here right now. Perhaps you guys go into your lecture, but post-ictal suppression is extremely important. Then there are things, like I said before, the presence of delta waves. Typically, you want that at least 50% or more. You want good interhemispheric coherence. So in other words, the left and right leads are fairly similar. That's another important one. You want to see good progression. So in the beginning of the seizure, like we saw, there was a sort of short amplitude theta waves that we were looking at that progressed into these nice delta waves that we're looking at. Then there's duration, which is simple. We typically want a seizure over 30 seconds of central seizure over 30 seconds. Motor seizure probably over 20 seconds.
What if the seizure is too long? What do you do?
We can abort the seizure. And I was going to say another marker that's outside of the EEG that tells us the seizure was good is the sympathetic activity. So this is something researchers will look at, how high did the heart rate go? How high did the blood pressure go? That is somewhat reflective of how potent, so to speak, a seizure was. Seizures generally stop on their own because for the most part, we're treating non-epileptic patients. We do treat epileptic patients, but generally speaking, we don't. So there's no epileptic focus, so these seizures stop on their own. But occasionally we stop a seizure simply because a seizure isn't really it doesn't show increased effect probably after 80 seconds, 100 seconds. So once a seizure goes that long, we usually stop the seizure by an intravenous drug, probably midazolam. Or if you're really in a bind, you could always just push the anesthetic drug that you're using because most of these anesthetic drugs are pretty anticonvulsant.
Right, that takes me to a different question here. When you choose an anesthetic here, what do you focus on? What anesthetic we would like to choose, and what do you want the anesthetic to do for you?
Yeah, so our gold standard in ECT, at least in the States, I would say, is methylhexatol. The brand name is Brevitol, brevity, short. So everything that we use here is quick onset and short acting. So that is the gold standard by which we've figured out sort of our algorithms to induce initial seizure with our charge settings and things like that. Methylhexatol is a barbiturate medicine that, it's a very, very anticonvulsant drug. It can be used to achieve anesthetic induction. Anesthesia doesn't use this drug anymore. It's a bit antiquated, but we still use it here in ECT. Occasionally, our patients have either a very low seizure threshold or a very high seizure threshold. Think of methylhexatol as sitting in the middle. So if a patient has a very low seizure threshold, these are going to be patients of young age and also of female sex. Those patients tend to have very low seizure thresholds. We might switch to an induction agent like propofol, also known as the milk of amnesia. It's that white induction agent that is extremely anticonvulsant. So we'll use that to avoid a prolonged seizure. Sometimes patients have a very high seizure threshold. These might be our older male patients, or because they're on a lot of benzodiazepine or anticonvulsants like Depakote. Then we'll switch to other drugs, something called etomidate, for example, or sometimes we'll even augment with synthetic opioids like remifentanil. These do not influence the seizure threshold as much.
Thank you very much.
طيب واحنا كده نكون وصلنا لنهاية المحاضرة. دي references that I used and I'm happy to take questions. خلينا توقف الشير. شايف في أسئلة كانت سألت قبل شوية. الفيديوهات حتكون في الفيديو في القناة في اليوتيوب. شايف في سؤال عن الرول بتاع الانستاتيك والإليسيت drugs. ما خالص شديد، ما أفتكر فيه major relationship. Space occupying lesion, they rarely come to ECT, and that relationship is not as strong as we believe to. It's still not an absolute contraindication for ECT. I want to ask about the substance and ECT, especially nicotine. Is there any effect to efficiency of ECT? I'm not aware of any effect with nicotine. For how long does the effective... I'm sorry, في واحد بيسأل سؤال، تفضل.
فتح العليم R32.
تفضل فتح العليم.
You have mentioned that treatment ECT is used in the treatment of resistant cases, and among those is intellectual developmental disorders. So my question is, to use ECT in the treatment for again or autistic adult or autistic other improvement, if it is proved in the symptoms or there is a possibility of ECTs in
الصوت قطع. انا سمعت انه الهناي ECT intellectual people with intellectual disabilities لكن ما سمعت السؤال.
What is the percentage in the improvement in the symptoms in these cases, such as in the autistic children or autistic adolescents?
Okay.
Is it effective? How effective is that?
Okay. طيب بالنسبة للسؤال ده بالنسبة للبيش في تعليم تاني عندك حاجة باقي في السؤال؟ طيب بالنسبة للpatient with intellectual disability ولا patient with autism spectrum disorder. Nowadays, people have recognized that these patterns of repetitive, non-contextual behaviors, and I'm talking about patients who are repetitively hitting themselves, punching themselves, scratching themselves. These are repetitive activities, repetitive non-contextual activities. And this is similar to what we call complex stereotypical behaviors. When they notice that this population have increase in the frequency or the change in the pattern of how these activities are happening, like we don't focus on calling them self-injurious behavior in itself. The nature of itself of how this can resemble what we call stereotypical behavior seen in catatonia. The frequency of catatonia among patients with autism spectrum disorder is close to 17%. And now even this number has been increasingly recognized to be more and more. So we're not treating their baseline. We're treating basically catatonia on top of autism spectrum disorder, manifesting in the form of repetitive non-contextual behavior, such as repetitively hitting themselves, aggression, excitement. We have a group of people, and we don't have data. Then it's a newly recognized group of patients that have been responding to treatment. We don't have data. Like according to our experience in patients here, the frequency, intensity of the repetitive self-harm behavior, excitement, improves significantly to the extent that basically they're able to function. And I can share with you at the end of this video, actually a video from one of our patients who they posted this on YouTube themselves before and after treatment to show basically how this is helpful. We're not treating their baseline. We're treating something on top of intellectual disability.
Thank you. It's clear to me. Thank you very much.
Thank you. So, نشوف الأسئلة. How does the effect of ECT treatment last? Well, it's variable. Some people sometimes might get one ECT treatment and they finish the course and they might not have anything for 10 years. Some people might, like a lot of people might relapse in the absence of treatment. So when we try to space out the treatment, let's say we get somebody who responded to 3 treatments per week. We start spacing it out to make it once a week, once every 10 days after that, once every 2 weeks, 5 weeks. As we space it out to hit 6 weeks, the symptoms come back. This is where we stop. And this is exactly when we call, this is the number of when we're going to do the maintenance treatment. Every 5 weeks, every 6 weeks. But everybody is different. Some people might have recurrence of symptoms immediately. Some people might take longer. Like Iman, can changing the dose of ECT be an option to reduce memory problem? Of course. Lakin at the same time, if you end up with a short seizure, the seizure is not effective. So we try to use the lower energy possibly to induce the effect. طيب. في سؤال من محمد, if patient is on clozapine, what will you do regarding DC or continuing taking clozapine before treatment? We ask the patient to continue clozapine. A group of patients with schizophrenia who are being treated for treatment-resistant cases, they continue to take the clozapine. We just adjust the parameters of the ECT. Let's say if we realize because of the clozapine, the seizure threshold is going to be lower, we use the lower energy. Mortality rate, سؤال من فتحية سعيد, mortality rate with ECT, it is extremely rare. It used to be more in the past before modern ECT. This is the reason why we do a consult, we do a medical clearance. Usually the concern about ECT is from anesthesia and subjecting them to anesthesia. And when you do an appropriate medical clearance, the rate of any unwanted side effects is extremely rare. However, as we treat a lot of older population here, sometimes they might have some you know, changes in, like they might have especially with undiagnosed congestive heart failure, you might end up with worsening of congestive heart failure. That's why like it's important to have an appropriate medical clearance before ECT, not to prevent the patient from seeking ECT, but to make sure like it's safe. Here in the United States, every patient who gets ECT has to be seen by the primary care physician and to be cleared for ECT on a monthly basis. And this is more just as a safe practice to make sure patients are safe. طيب محمد جلال بيسأل عن consent for catatonic patient for ECT. Depending on where you practice, every state here has different rules. Here we have to obtain a court order from the judge to treat the patient. It takes almost between 3 to 5 days to get the court order for treatment. In a different state, you can ask the family and they can consent on the patient's behalf as long as the patient is not refusing. Let's say the patient is mute, not able to like exercise their right or opinion, express their opinion. They're not saying yes or no. They're not refusing. Sometimes family can consent on their behalf. لكن إحنا مثلا في الولاية حقتنا, no, you have to obtain a court order. And in order to obtain a court order, you have to show to the court that the patient is not eating, not drinking. If the patient, or basically if aggressive patient hitting everybody. For a patient with autism spectrum disorder, usually they have a guardianship. So somebody from the family who is a guardian for them, they tend to also go and obtain a specific guardianship so they can consent on their behalf for ECT. Fatma, why do some patients, after initially responding well to ECT, experience episodes of choking lasting more than 20 seconds and subsequently develop resistance or have seizures lasting than this? Okay, شوية السؤال ده شوية ملخبط ليا. So, have experience of episodes of choking lasting more than 20 seconds. And if I'm understanding this correctly, this is separate from the other half of the question. Now, some people sometimes might have a GI spasm. We have some patients who have esophageal spasm. I don't know if it's an allergy from medications or even from the ECT. I've never seen it. I've heard about it, like I've never seen it. So it's not a common thing. And subsequently develop resistance or have seizures lasting than 20 seconds. 20 seconds, احنا بنتكلم عن inadequate energy in like they're currently, or basically if you're using, let's say, يعني a lower energy, they might not have a seizure. They're using benzos, they might not have a good seizure. They might use, we talk about a seizure threshold. How to overcome a seizure threshold? This is exactly when you need to increase the energy. As you mentioned, when we do subsequent treatment, the seizure threshold tends to go up gradually. And this is why you have to go with the higher energy. حمدي, more simplifying procedure. معلش ممكن تشرحي سؤالك شوية ما واضح لي.
Asking about can we more simplifying the procedure and decrease use of anesthesia or something like this? Decrease or using simplifying way of electricity or something like this.
ما في حاجة حاليا بالطريقة زي دي. افتكر this is بتكلم عن الاوبشنز الثانية اللي هي مثلا TMS, لكن ما
TMS. Okay.
TMS, this is a separate form of treatment. It's a complicated for this يعني purpose of the lecture يعني, and I'll stay away from it. Like it's an option for different modality of treatment. Is not as effective, is not as fast. It does not work well for treatment resistant cases.
Okay, thank you.
يا دكتور.
أيوة تفضلي.
نمارق الحسن. I want to ask about in your pre-treatment counseling with the patient, do you give them the right of to choose which modality you will give them, either unilateral or bilateral?
Yes. So we explain to them exactly يعني, that bilateral treatment is more effective, requires fewer number of treatment, but is more likely to cause memory problems. And right unilateral is less effective, requires more number of treatment, less likely to cause memory problems. And they tend to choose, depending on the severity of the illness, we might give an opinion. So patient with keratonia, like we just go bilateral treatment. Patient with severe illness, patient with treatment-resistant schizophrenia, bipolar, we go with the best modality. If you have a patient who is a teacher, a lawyer, and nothing is urgent and they're scared of having memory problems, sometimes they might choose, but we warn them that it might not work. And if it does not work, we might have to switch to bilateral treatment or the other way around.
Thank you.
Okay. طيب أنا رسلت السيرفي في الجروب هنا في الشات. الناس بس عليكم والله ما تنساهوا بالذات بعد المحاضرة الطويلة. معلش شديتكم معي في المحاضرة، لكن بس عشان الزمن طول أنا أفتكر ننهي المحاضرة. إذا الزول عنده أي question later on ممكن يرسله بعدينك في الإيميل.